Calcium is the next electrolyte that I want to talk about. Calcium balance is controlled by your parathyroid hormone as well as calcitonin and your vitamin D. So your parathyroid increases bone resorption, so movement of the calcium out of the bones. And so it increases your GI absorption of calcium and increases your renal tubule reabsorption of calcium. Calcitonin, though, opposes the action of your parathyroid hormone, so it reduces your serum calcium by decreasing your GI absorption and increasing your calcium deposits into the bone, and also promotes that renal excretion of your potassium. So when we're looking at hypocalcemia, that means that we have low levels of calcium. It can be caused by a decreased production of your parathyroid hormone. It could be related to an acute pancreatitis. It also can happen from multiple blood transfusions. So remember, when we do packed cells, we're giving red blood cells, but we're not giving as many of those other electrolytes. So we might see some of those electrolyte abnormalities. We may see hypocalcemia in alkalosis, or we could see it in a decrease in intake. So what happens is low calcium levels allow sodium to move into excitable cells, so it decreases the threshold of the action potentials and that depolarization of cells. So the result is that you have nerve excitability and a sustained muscle contraction, and that sustained muscle contraction is called tetany. So I have a slide next, and Jody probably talked about this as well. About how to test for hypocalcemia. Sorry, hypocalcemia. So cardiac effects, of course, we can see that decreased cardiac contraction and EKG changes. And the treatment is going to be to treat the underlying cause. And so it could be an oral or IV calcium supplements. It should include a vitamin D supplement. And then we need to monitor our patients who go for any type of neck surgery, especially a thyroidectomy, really closely, because if we damage or inadvertently remove the parathyroid gland, then we can see a drop in that calcium that can lead to a severe muscle spasm that can lead to cardiac problems and those types of things. So hypercalcemia is, we can see where there's been the treatment would be to excrete calcium with a loop diuretic. So hypercalcemia can happen with hyperparathyroidism. It can happen in malignancies, so such as a multiple myeloma, which is actually a lymphoma or a blood type of cancer, but it causes tumors on the bone, and the breakdown of the bone releases calcium. It can be a vitamin D overdose, or it can be from prolonged immobilization. So laying in bed causes the calcium to leave your bones, and a hypercalcemia can result. So how we're going to get rid of it is using those loop diuretics. So excretion of calcium can happen through the kidneys with a loop diuretic. We also want patients to drink between 3,000 and 4,000 milliliters of fluid a day, and that's because a high calcium can cause kidney stones, and we want to keep those kidneys flushed. You might see hydration with an isotonic saline solution. Again, let's dilute that calcium and get it excreted through the kidneys. You may see a synthetic calcitonin. So remember, calcitonin has the opposite effect of a parathyroid. We want to increase mobilization because that's going to put calcium back into the bones. And then there is a medication that might be used, pamidronate. And this, the dronates are medications that we'll cover when we're looking at osteoporosis in term 6. But it is one of those medications that helps put calcium back into the bones. So it's a treatment for osteoporosis. But I thought I would mention it here because it does help reduce that high circulating levels of calcium. So So the test for hypocalcemia, so if we see a patient that's inadvertently had their parathyroid gland removed in a thyroidectomy or any type of neck surgery, we would watch for these two signs. And the top one is that Chvostek's sign, and that is a contraction of the facial muscles in response to a light tap on the nerve of the face. So you tap the nerve in front of the ear, and if you see the face jerk towards the finger, so almost like a rooting reflex in a neonate when you touch their cheek, but in this case you tap in front of the ear and it causes a muscle spasm. It's a sign that there is a low calcium. The other is that Trousseau sign, and that is a spasm of the carpal spasm in here. So when you put a blood pressure cuff on and inflate it, it triggers the nerve to cause the hand to flex in, and that's called a positive Trousseau sign. So we watch these signs on patients that have had neck surgery to make sure that we haven't lost their parathyroid gland and dropped their calcium. So the next electrolyte I want to talk about is phosphate. So it's our primary anion of our intercellular fluid, and it's essential to functions of muscles, your red blood cells, and your nervous system. It is deposited with calcium in the bones and in your tooth structure. It's involved in your acid-base buffering system, and it is maintained through your renal function. So it's one of those that goes elevated if your kidneys aren't excreting it properly. And it has an inverse ratio with calcium. So as phosphate goes up, your calcium goes down. And if your calcium goes up, then your phosphate goes down. So a low phosphate can be caused by malnutrition, alcohol withdrawal, or the use of phosphate binding antacids. So some antacids that are a calcium base, they bind to phosphate and they remove the phosphate through the GI tract. And so that means that we can fix hypophosphate by using an oral supplementation. So ingestion of foods that are high in phosphate, which includes your milk and your dairy products, or you can use an administration of either sodium or potassium phosphate. So we can increase that serum phosphate by using supplementation. In the case of hyperphosphatemia, we see that in patients that have acute or chronic renal disease. We may see that happen with chemotherapy, or we might see it if someone has overdosed on a phosphate or phosphate-containing multivitamin or a vitamin D supplement. So we would want to treat the underlying cause, restrict those foods and fluids that have phosphate in them or phosphorus, and then to make sure that they're adequately hydrated to correct that hypocalcemia conditions. In our renal patients, we would use a phosphate binder, which would reduce that phosphate, and that is a calcium supplement that's given with the first bite of food to help bind to that phosphate to be eliminated out of the GI tract. The other way of removing phosphate, if it's serious and the patient's in renal failure, would be through that dialysis. All right, so the last electrolyte that I wanted to talk about is your magnesium. And the majority of our magnesium is contained in the bones, and it is regulated by the GI tract. The kidneys are able to conserve magnesium or excrete magnesium. And sometimes the manifestations of a low or a high magnesium are mistaken for calcium imbalances. So all three, your calcium, your phosphate, and your magnesium, as well as potassium and sodium should all be monitored so that we know there is a difference between the calcium and the magnesium as to which one is being low. So our low serum magnesium can be caused by starvation or prolonged fasting, by chronic alcoholism, by fluid loss from the GI tract again, so vomiting or GI suctioning, or it can be from prolonged parenteral nutrition without adding magnesium. So we just haven't maintained those electrolytes. We can also lose magnesium with the use of diuretics. So if it's a low magnesium, we would use oral supplements. We would increase the dietary intake, and then there is parenteral IV or IM magnesium when it is severe. So hypermagnesiemia is from an increased intake or ingestion of products that contain magnesium when the kidneys aren't quite working well enough to control that and help excrete it. So anyone that has chronic kidney disease that's ingesting products that have magnesium, so things like Malox or milk of magnesia, can be a problem in causing too high of a magnesium. So the best way to treat this is prevention, of course. So making sure that patients that have renal problems know they should avoid Malox or milk of magnesia because of the high magnesium, to minimize the amount of magnesium containing foods. And in an emergency treatment, we may want to use calcium gluconate and then fluids to help excrete it. So our nursing implications when we are replacing fluid and electrolytes, we want to know a baseline, right? So have a baseline fluid volume and electrolyte status. Make sure you're watching the patient's specific gravity of their urine as well as their electrolyte status. We want to have baseline vital signs. We want to assess the skin for signs of dehydration. So like I said, pinching the skin on the abdomen or the sternum or the forearm may tell us the hydration status of a patient. Again, when you're looking at patients with that are older and have decreased amount of elasticity in their skin, it may not bounce back quite the same. So in that case, we may want to monitor their mucous membranes, do daily weights, monitoring their intake and their output. We want to check the potassium levels on a patient's electrolytes before we're giving them the potassium, and we may need an ECG to make sure that their cardiac status is stable enough for that potassium supplement. We may need an IV access if we're giving IV electrolytes. We'll monitor their serum electrolytes during therapy. So if we are running sodium chloride or we are running potassium chloride, we're monitoring those electrolytes closely. Most of the electrolytes are considered irritating to the veins, so we're going to want to monitor for infiltration of their IV sites. Potassium particularly causes venospasms and makes the vein hurt, so we want to make sure that it's running in the vein, that it's not infiltrating around the vein, and we may even need to wrap the arm in a warm blanket for pain control during a potassium supplement. Parenteral infusions of potassium must be monitored closely. Like we said, IV potassium cannot be given at a rate faster than 10 millimoles per hour who are not on a cardiac monitor. For critically ill patients on cardiac monitor, then they may go up to 20 millimoles per hour. But we never give potassium as an IV bolus or undiluted. I'll have to tell you a story about potassium med error in a unit that I had worked when I was first in nursing, and I'll talk about that in class.